So in this lecture, we're going to look at the bacterial diseases of the respiratory system.
So of course the main function of the respiratory system is gas exchange, but remember that when we exhale that carbon dioxide, we're also buffering the pH throughout the body. So it's an important function as well to think about. We have generally two halves of the system anatomically speaking. We have the upper and lower respiratory systems divided essentially at the larynx, which is the voice box. Now, of course, the anatomy and physiology of each of these systems differs a little bit. The upper respiratory system is designed to trap and filter particles so that they don't get into the lower system. But we can also just think of it as a general pathway for airflow. Remember that there's a connection between the middle ear and the nasopharynx, which is the eustachian tube, also known as the auditory tube. And so we have a connection there between that middle ear and the pharynx. And so when we get to talking about things like sinusitis and otitis media or ear infections, it's because there's a connection between those two systems. Now remember, in the lower system, the functional areas are primarily the alveoli. So these little air sacs where gas exchange is happening is primarily made of three kinds of cells. The wall of the alveolus itself is made of type 1 pneumocytes. This is where gas exchange is happening. We have type 2 pneumocytes, which are these little green ciliated cells here. These are the ones that secrete surfactant. And surfactant is critical to keeping those alveoli from collapsing on themselves, because if they're collapsed, then they can't function in gas exchange. And then we also have the alveolar macrophages, sometimes called dust cells, which are the phagocytes that are constantly surveilling and cleaning the surface of those alveoli, and they clear any pathogens that find their way into that airspace. One of the most important protective features of this system includes cilia. So the trachea is lined with cilia, and they're constantly sweeping mucus up and out of the trachea, and then it gets swallowed down into the esophagus, where the pH of the stomach can kill anything that's been trapped and removed from the respiratory tract. So keep this in mind, because several bacterial diseases are going to specifically target cilia. So by either just sticking to the cilia or by secreting toxins that interfere with the function of the cilia. So if you take out this ciliary escalator, you're basically giving particles or pathogens access to the deeper part of the respiratory system. Other defenses include the resident microbes. Of course, just like in other parts of the body, they're there to provide competition for pathogens. The mucus itself is very sticky, trap those microbes. We have reflexes, of course, associated with clearing the respiratory system. We think of sneezing as the reflex that clears the upper respiratory system, whereas coughing is the reflex that clears the lower respiratory system. And then once we get into those alveoli, we have, again, those macrophages that we talked about. And all throughout the system, anywhere you have mucus, of course, you have the secretory antibodies, which are the IgAs.
And given that the respiratory tract is one of the major portals of entry into the body, we're going to have quite a few diseases in this chapter. So bacterial pharyngitis is typically caused by Streptococcus pyogenes, which we've seen in several other diseases. So most people think of strep throat, and it's really describing a group of diseases, because there are more than 90 different strains. So when people get Streptococcus or strep throat multiple times, it's probably a different strain each time. And so this is typically what we refer to as either streptococcal respiratory disease or just simply strep throat. Transmission here is via respiratory droplets, and we do see sort of a seasonality when it comes to strep throat, and most often in the winter and the spring, when the air is drier and particles can travel farther. So it's a lot easier to transmit any pathogen that can travel through the air is going to travel farther in drier weather. So we do have effective antibiotics if it's diagnosed properly. Unfortunately, antibiotics are very effective typically. So within 24 hours of starting antibiotics, even if all the symptoms are gone, you're typically no longer infectious. So there are a variety of virulence factors associated with this group A strep, and when it comes to the strep throat version of infections, most of them carry what we call super antigens, which is basically going to trigger the immune system in an exaggerated way, which largely leads to a lot of the tissue damage that we see. There's also a unique version of lipoteichoic acid in the cell wall that allows these organisms to more readily adhere to the lining of the throat. We've talked about M protein, which again is a surface antigen on Streptococcus pyogenes that both allows it to adhere but also interferes with phagocytosis. And there's also an idea that it triggers more cell-mediated tissue damage as well. So it kind of correlates with that super antigen function. And then we have what's called a streptolysin O and S, and these are two enzymes essentially that are secreted by this strain, these strains of bacteria. So we call them hemolysins just strictly because that's how we detect them in the lab. So the hemo that they're talking about is chicken blood. So there's a certain assay that they can do, and if it lyses the chicken blood cells, then it's detecting these enzymes. But in the human body, it basically just targets and damages the cells lining the throat and can cause tissue damage there. There's also erythrogenic toxin, which is partly what triggers the rash and fever associated with strep throat.
So there are a number of other pathogens that can cause pharyngitis, including some like this one, Fusobacterium necrophorum. We're still learning about this bacteria, but they actually suspect that it causes about the same number of cases as the Streptococcus species. Unfortunately, we don't have any readily available diagnostic tests. Most of this is in retrospective research type of situations. And so one problem with this species is that if it goes untreated, it can cause very severe conditions, especially in immunosuppressed or elderly patients. And so what's unfortunate is you suspect strep throat, you do a strep test. If it's negative, then they suspect, well, it must just be viral pharyngitis, right? If it's not diagnosed as strep, we assume it's viral. And so this is really problematic because if you assume it's viral, you withhold antibiotics. And then if it is this particular bacteria, it can progress to a really severe form and even be fatal to some patients. And so this is just one of those reasons why doctors sometimes go ahead and prescribe antibiotics, especially if they're a high-risk patient, just in case, right? Because if you don't get ahead of it, this can become a really severe form of the infection. Viral pharyngitis tends to be a little more mild in general. And one way that they sometimes can distinguish between the two is when you have viral pharyngitis, very oftentimes you lose your voice because of the way the virus affects those mucosal layers that we call the false vocal cords. When you have inflammation of those false vocal cords, they literally sit on the regular true vocal cords and you lose your voice. So it's not a end all be all of diagnostics, but that is one way that they can sometimes distinguish this. And so it's unfortunate that, to be better to be safe than sorry, they go ahead and prescribe antibiotics, which of course is just leading to or adding to the resistance problem with antibiotics.
So because of the connection of the middle ear and the sinuses to the respiratory tract, specifically to the nasopharynx by way of the eustachian tubes, or what are more modern name is the pharyngotympanic tubes, we have these diseases in this chapter as well. So when we call essentially an ear infection or a middle ear infection is acute otitis media, and sinus infections would be sinusitis. And they're largely caused by the same groups of organisms. And there are a wide variety of organisms, including viruses that we don't really diagnose. But Streptococcus pneumoniae is the primary bacterial cause for either of these. There's also a strain of fungi, so Candida auris is a possible cause for ear infections and sinus infections. And transmission, largely, it's unknown other than the fact that there's a clear connection to the pharynx. And so it's likely any organism that gets into the nasopharynx can get up into those deeper spaces. So the only one we can actually prevent would be for Streptococcus pneumoniae. So we do have a vaccine, what we call the pneumococcal vaccine, which basically is designed to prevent meningitis and pneumonia, but it can also provide some protection if that's the species that is the cause here. So we do have antibiotics typically. Sometimes they require multiple rounds of antibiotics because of where they're located, and a lot of these deep tissues are hard to treat. And so typically we see middle ear infections in young children, partly because that connection to the middle ear from the nasopharynx is so short. Sinusitis tends to be more common in adults. And so depending on where the infection is, because inflammation brings fluid, and it can cause inflammation inside that middle ear and put pressure on the tympanic membrane or the eardrum, we can put tympanostomy tubes in there to help drain that fluid and relieve the pressure and relieve the pain associated with otitis media. Pneumonia is going to be caused by a variety of organisms, many of which are bacterial. And so characteristic pneumonia is just anything that causes fluid to be present in those alveoli. Recall, for gas exchange, you need airspace, not a fluid-filled space. And so any inflammation can be called pneumonia. So typically bacterial pneumonia is going to be the most serious form, and it's going to be the most frequent form that we see in adults. But typically they're going to name pneumonia either by the organism that causes the disease or by the region that it's affected. So for example, if they call it bronchial pneumonia, it's going to be in the bronchioles. If it's lobar pneumonia, it's involving essentially the entire lobe or the alveoli of the lungs, as opposed to, for example, pneumococcal pneumonia that we just mentioned, or fungal pneumonia when we get to the next lecture. So the most prevalent form of bacterial pneumonia tends to be caused by Streptococcus pneumonia, and we call this pneumococcal. So recall we met this same species when we talked about pneumococcal meningitis. And just like any bacteria that has adhesins, it gives it the ability to stick to the tissues and cause infection. Most bacteria that are pathogenic also have capsules, and that is characteristic of Streptococcus. But this strain, when it gets into the respiratory system, can also secrete something called pneumolysin, which basically just kills the pneumocytes, which is the fancy name for the type 1 epithelial cells that line the alveoli and are responsible for gas exchange. So transmission, again, respiratory droplets. Signs and symptoms are going to be typical across all the different forms of pneumonia that we see, and it's going to include things like fever and chills, congestion and cough. Antibiotics are effective if it gets diagnosed properly, and so this is one form of bacterial pneumonia that does have a vaccine that is effective, and so we have one called Pneumovax that we use particularly for adults. And because Streptococcus, remember, it belongs to a group A strep, and so this means that multiple strains can cause the infection. And so the 23 most common strains that belong in this group, they've taken little pieces of the capsule, and that's what they use to make the vaccine against. And so this is going to hopefully be protective against multiple strains. Then we have what's historically called walking pneumonia, and it's more officially called primary atypical pneumonia or mycoplasmal pneumonia because it's naming the organism. So mycoplasma is a very unique bacteria in the sense that it's one of the pleomorphs, meaning every time it replicates it has a different morphology, which makes it very difficult to just look at under the microscope and determine which one it is. But just like other pneumonia-causing bacteria, it's going to have adhesins that allow it to stick. And in this case, these guys have an affinity for the cilia. And so if you can stick to the bottom of the cilia where the motor proteins work to move the cilia back and forth and paralyze it, then that just prevents the ciliary escalator from doing its job to remove them. Signs and symptoms, one reason why it's called walking pneumonia is because the symptoms are typically so mild that people continue going to work. They just feel a little bit run down, but not severe. And so if the disease progresses, you might have some more typical pneumonia-like symptoms. But typically what people see is a long-term, very dry cough, but otherwise feel fairly normal and continue moving about and going about their daily lives. So again, respiratory droplets are the primary mode of transmission, but it can also be transmitted through indirect contact. So again, if someone blows their nose and doesn't wash their hands and touches the remote or the door handles, things like that, then it can be transmitted by way of those fomites or inanimate objects. So diagnosis for this particular version of pneumonia is particularly hard, partly because those pleomorphs, number one, look different under the microscope every time they replicate, so it's hard to get a conclusion on the morphology, but they're also incredibly slow to culture and very small organisms. The other problem is genetically they're gram-positive, but this is the one group of bacteria that lacks cell walls. So you can imagine if you put these microorganisms through the gram stain procedure, which is typically the first thing we do, gram-positive organisms should look purple, but because these guys don't actually make a cell wall, they're going to get decolorized much like the gram-negative cells. So they're going to come out looking gram-negative, even though they are in fact gram-positive bacteria. So if it does get diagnosed properly, then we do have effective antibiotics. And because respiratory droplets is how it's spread, and because most people have very mild or asymptomatic cases, it's difficult to prevent this because there's not a clear set of symptoms that tells people they should either get tested or stay home. So just like other respiratory diseases we're going to hear over and over, even though it's a respiratory disease, washing your hands is absolutely the key to preventing most respiratory diseases because of those fomite transmission. So you touch a doorknob and then you touch your own eyes or nose and you've self-inoculated yourself. And there are no vaccines against this mycoplasmal organism. So this is, again, hand washing is always the best prevention during cold and flu season because of the way these respiratory diseases are spread. Then we have a group of pneumonia, bacterial pneumonias that your textbook lumps together as healthcare associated pneumonias, but they've just briefly mentioned it, so we're going to talk a little bit more about each of these. So Klebsiella pneumonia is the primary nosocomial form of bacterial pneumonia, and this one has a very thick capsule, which is really all the virulence virulence factor that it needs to survive, but it's also a gram-negative bacteria, which produces endotoxin again. So we've talked quite a bit about endotoxin. So this one's unique in the sense that it is not droplet or airborne. It is strictly through direct inoculation of contaminated equipment going directly into the respiratory tract, which is why it is typically associated with healthcare. So someone goes in for a surgery that's completely unrelated, gets an endoscope or a ventilator or something that has not been properly disinfected, and the bacteria is then directly inoculated into the tissues where it will take its effect. The other way that it's commonly associated with hospital settings is that patients can aspirate bacteria from their upper respiratory system down deeper into their lower respiratory system. So because this is primarily nosocomial in nature, either hospitalized or immunocompromised and smokers are going to have the highest susceptibility to this form of bacterial pneumonia. So we don't have any vaccines against Klebsiella. we really have to rely on having proper aseptic technique, especially in the healthcare setting, because that is the primary mode of transmission. So proper care of the equipment, proper disinfection of anything that might come in contact with the respiratory tract. Any patient that is especially susceptible should make sure that they are elevated so that they can avoid aspiration. And before surgery, making sure that patients know that after that respirator has been removed, that they need to breathe deeply and cough frequently to help avoid transmission of those organisms into the. So signs and symptoms are going to be very typical of pneumonia, but we will also see a very thick, bloody sputum, because when the bacteria gets into the alveoli and kills them, then it's going to produce blood. So this is actually one of those distinguishing factors. So we'll talk about other forms of pneumonia. If it's not a thick, bloody sputum, then it's probably not Klebsiella. Patients often typically also have recurring rounds of chills associated with that infection. So diagnosis, signs and symptoms, plus a sputum culture. So we can culture Klebsiella. There's some special media that they can use to distinguish that bacteria. And because of the damage that it does to the respiratory system, really prompt diagnosis and antibiotics is really key. And multi-drug regimens are usually required, mostly because there are many resistant strains that have developed. One of the most important ones clinically has developed resistance against carbapenem. So this is how they usually refer to that particular strain as CRKP, carbapenem resistant Klebsiella pneumonia. And otherwise, supportive care is about all we can do for these patients. So we talked about bubonic plague, but recall that pneumonic plague essentially forms a pneumonia-like infection. And so again, the species is Yersinia pestis. It is transmitted through either respiratory droplets, or recall bubonic plague can be transmitted through blood or the bite of an infected flea, and if it finds its way into the respiratory system, it can be turned into pneumonic plague. And so again, signs and symptoms are going to be typical pneumonia symptoms, but this one will have a more frothy, so more, think bubbles, as opposed to a thick, bloody sputum. So that was one of the distinguishing factors between Klebsiella and pneumonic plague. Then we have a respiratory disease called Legionnaire's disease, and this is caused by a bacteria called Legionella pneumophila. There are several species, but that's the most common of the group. But this is a unique bacteria in the sense that it actually lives inside of an amoeba, which is why this is associated with contaminated water, because the amoeba host has to be in a water body of some sort. And so inhalation or ingestion of this contaminated water, so think the most common forms, in fact the original, when they described the disease back in 1975, it was when the Legionnaires, which was a group of veterans, got together to celebrate the centennial, and in the hotel where they were all staying, the water source had gotten contaminated, and so it gets aerosolized in the shower and you breathe it in, and that's how they tracked it back to a very large number of cases that were in that one hotel. But since then, we've also found that cases can be transmitted in saunas and hot tubs, any place where the water gets aerosolized, as well as in ingesting vegetables that have been misted with contaminated water. So if you've ever gone through the produce section of a grocery store, that little fine mist that is released onto the vegetables, if that water gets contaminated, then those vegetables are now contaminated. And if you don't wash those carefully, then it can be transmitted that way. So we've had a few cases traced to that form of transmission. And so again, typical pneumonia symptoms, but this can lead to much broader complications that can involve the GI, the nervous system, the liver, or kidneys, and can be fatal. So this bacteria preferentially infects and kills epithelial cells. So imagine that is the type of cell, number one, that makes up the alveoli of the lungs, which is the starting point. But if it gets in any of those other tissues, so we just mentioned the liver and the kidneys, those blood vessels that are highly vascular organs are going to be affected when their blood vessel linings, which are epithelial as well, get killed. So the susceptibility here is primarily in elderly patients, which is why it's named Legionnaire's disease. That example I just mentioned of the very first cases developed, those were veterans. They were all elderly men. Most were smokers, and many were immunocompromised. So it was like the triple storm, or the perfect storm of those components coming all together. So prevention, proper maintenance of any system that has water in it. So think hot tubs, even AC units. If they're not properly maintained, you can get puddling and condensation, which then provides a place for those amoeba and the bacteria in the amoeba to grow. And it turns out those amoeba and the bacteria are very tolerant of chlorine. So if there's not a proper amount of chlorine being used in those systems, then it can allow them to grow. So treatment, because it does such physical damage to the lungs and invites inflammation and invites fluid into the lungs, it's really critical that prompt diagnosis and antibiotic treatment begins. So we do have effective antibiotics, but they really need to be given very early in the progression of disease to avoid those complications and death. Then we have tuberculosis, which most people think of as an ancient disease, but it's actually resurged quite a bit globally. So the organism here is Mycobacterium tuberculosis. Recall this is a sister species to Mycobacterium leprae, which causes leprosy or Hansen's disease. So there is actually a tuberculosis of cattle that can rarely infect humans. Historically, it was a common transmission, but it's not as common anymore. But that one would be Mycobacterium bovis. The clinical forms, it's really complicated to surveil and detect tuberculosis, partly because it can be active or latent or resurgent or cured. There are many different stages. And so generally we think of the pulmonary form, and then we think of the disseminated, or what's sometimes called extrapulmonary tuberculosis, and that is where it involves multiple organ systems. And historically, we would call that version consumption, because it literally sort of consumed you from the inside out. It would damage many different organ systems. So immunocompromised individuals are at the highest risk. Many people are walking around with asymptomatic carrier state, and so if your immune system can keep it in check, it's usually not a problem. And so this is where immunocompromised systems are really the highest susceptibility. In fact, this is the #1 killer of HIV/AIDS patients. So recall we said HIV doesn't kill the patient. HIV kills the immune system, which then allows secondary or defining diseases like tuberculosis that a healthy immune system would be able to keep in check, allows it to take hold. So we'll look at the progression of disease, sort of the aerosolized bacteria in respiratory droplets can get into the lungs. Either your immune system repels them, or the person is uninfected, or it can find its way into the lungs and infect those tissues. And so what happens is the macrophages, the alveolar macrophages in the lungs, will actually consume the bacteria but are unable to destroy the bacteria because the lysosome cannot fuse with the phagosome. And so those infected macrophages actually replicate and allow the bacteria to replicate within them, and so they basically become a home. Eventually, those macrophages will send out signals to the immune system. So T cells will come along, and recall T cells are typically designed to go after intracellular pathogens. Typically, those are going to be viruses, but they're usually going after tissue cells and not immune system cells. And so it's a little bit of a confusion between the immune system cells. And so instead of destroying them, the T cells create what's called a granuloma, which is basically where they wall off those infected macrophages. And so in many people, that granuloma basically keeps it in check. And those bacteria are sort of held in place in the lungs, and they're not allowed to escape. In people whose immune system is immunocompromised, that granuloma can rupture. It's not able to retain those bacteria in the lungs, and then they escape. And so if they find their way to a lymph node or a bloodstream, they can disseminate and find their way into other tissues. In many cases, even if the granuloma is intact, right, if they can go through stages where the bacteria is escaped and they go into other tissues, but then it can go into a latent stage if the immune system gets ahead of it. And so it's a really difficult disease to surveil, because even latent infections can disseminate if that bacteria then is released at some point in the future. So again, the virulence factor mirrors those of leprosy. The mycolic acid in the bacteria has a variety of effects. We know that it helps them from drying out. So desiccation, when a bacteria is not inside of a host, then it dries out. But that mycolic acid allows them to remain viable for longer periods of time outside of the host. Protection from lysis. So this is one of the main reasons why those macrophages are unable to destroy the bacteria when they are phagocytized. Also, that waxy layer, the mycolic acid, keeps many antibiotics that are water soluble from entering the cell in the first place. So that alone gives them, makes them difficult to destroy with antibiotics. But the strains of tuberculosis that are virulent all have something called cord factor, and this is basically something that allows, when the bacteria start to replicate, they stick together in a way that's different than what we would see, for example, like a chain arrangement. So don't think streptococcus when you think of these guys sticking together in parallel arrangements, because these are actually bacillus. So they are when they stick together, they basically create a cord, a barrier that neutrophils, if they were to show up in the lungs and try to help with this bacterial infection, they actually can't migrate through the infected tissue because of this cord factor. In fact, we know that strains of tuberculosis that are unable to make the cord factor are actually avirulent, and that's one reason why some people's immune system can keep them in check and others can't. It partly depends on the strain that you're exposed to. So diagnosis, again, the challenge is the fact that some of the tests that we have can only detect exposure. It can't detect whether it's a latent infection, an active infection, whether it's a local or a disseminated infection, or if it's a past infection that's completely cured. So the two primary tests that we use here in the US, the ones that most people are familiar with, are the skin test, which again is going to be where the protein is injected in the skin, and then you're basically waiting for your cell-mediated immune system to come and respond to that in a couple of days. And so this is somewhat problematic if you're testing someone who is, for example, homeless or doesn't have health care. Asking them to come back to look at the results in a couple of days is sometimes problematic. There's a newer test, because there is a vaccine that's used in other parts of the world, the BCG vaccine. Any immigration it's going to create a problem here in the sense that if they were given the skin test, it's going to show positive because of the vaccine that they were given. And so there's what's called the interferon gamma release assay. So this is actually the preferred test for those who've been vaccinated. So historically, how they tested was to take a sputum culture, but to grow these guys in the lab, partly because of that mycolic acid, it is such a slow growing bacteria that it takes 4 to 5 weeks in a culture situation to get a positive result, to be able to see them under the microscope. It's also difficult. You need special media and to culture them. And then once you've cultured them, now you have a live bacteria that you have to dispose of. And so it creates a biohazard that a lot of labs and hospitals don't. So because of the difficulty with this disease, there have been a lot of research, a lot of different tests researched. And so trying to get one that's a molecular test, that's a very fast test, that's much more specific, would be a microarray. If you recall from chapter 15, we talked about some of those types of tests. So a sputum microarray test does a couple of things. Number one, it's very fast. Number two, it can actually look for more than just the presence of the bacteria. It actually looks for biomarkers that are basically proteins that get secreted from the bacteria when it's in active form. So this is one good way we can detect the difference between active and latent infections. If a facility gets the original equipment in place, then it becomes a very cost-effective type of test. The other advantage here is that because it's very specific, it can detect genetic sequences. It can actually detect some antibiotic resistant strains. There are antibody tests available, which basically just looks for the antibodies in the blood. But again, this requires some special equipment. It also takes longer than the microarray tests. But it doesn't have the advantage of distinguishing between active or latent infection. And also, it hasn't been validated. So again, we have some other promising tests sort of in the future that will hopefully be useful, especially in poor countries that maybe don't have the culture labs option and things like that. So most of you have worked in healthcare in some way, shape, or form, and probably have to routinely get the TB skin test if you work in healthcare, because you don't want to be an asymptomatic carrier and work with susceptible patients. And so the test that we actually use today has been modified multiple times. The original test was the Mantow test, but they have kind of gone through and changed how it's been made. And so you might see these different names for what we just typically call the skin test. And what they're doing is when they introduce the proteins from the bacterial cell wall under the skin, then your cell-mediated cytotoxic T cells will then come to the location of that protein. And if they recognize it, they will destroy the tissues around it. And it creates this red swelling that's known as an induration. And then that will be measured and compared to a series of standards, essentially, and put you in a particular category to determine whether you're positive or negative. And so the categories are designed to take into account the effectiveness of your immune system. And so the problem is that response requires that you have a healthy, robust immune response to it, and it's detecting your previous exposure. So again, so if you're in category 1, anything over a 5 millimeter induration is considered positive. And so in this case, you're talking about anybody who has contact with an active TB patient, anyone who's HIV positive, because your immune system is potentially limited. So you may only be able to have a very small response. If you have a history of a TB infection that's been confirmed with x-rays of the chest that detects those tubercles, then you would be considered positive with only a very small response. Category 2 is if you're HIV negative, meaning you still have a fairly robust immune system, but you are an IV drug user. That puts you in Category 2. Persons with other medical conditions that increase the risk, such as diabetes or kidney disease. Those persons who live and work in high-risk areas, so any place that you have crowding or high-risk individuals in those areas, so places like jails and homeless shelters would put you in Category 2. And if you're a new immigrant from an area that has a high incidence of TB, you would be in Category 2, which requires a minimum of a 10 millimeter response. People that live in low-income areas, we historically would think of this as a disease of the poor, partly because early on when tuberculosis was very common, the only treatment available before we had antibiotics was essentially fresh air, good food, and rest. And only the wealthy were really able to leave the crowded cities and go to their country home or go to a sanitarium where they were given, rich food and fresh air and were kept away from other people that were infected. And so the people they basically were left behind were the people who were poor. And so that still kind of carries over in the sense that when you're low income and don't have access to medical care, then you're in this higher risk category. And typically, the minority groups and the way that the health department determines which group you're in really has a lot to do with your own community. And so each community has its own sort of list of who gets put in these different categories. And any child in contact with anybody that is in those high-risk groups as an adult would also be in this category. And then Category 3, you would have to have a pretty significant in-duration response, 15 millimeters or more, to be considered positive if you're anyone that doesn't belong in those other categories. So again, it's really trying to capture a combination of your environmental circumstances, your immune response, and otherwise, it can only identify that you've had previous exposure. It cannot distinguish whether you have an active latent infection or have been vaccinated, which is why the test is coming back positive. So if it does, if the combination of the in-duration size and your category comes back positive, then they still need to go and confirm the presence of tubercles. So recall those tubercles in the lungs are basically how your immune system walls off the bacteria. And some of the layering in that granuloma will capture and incorporate calcium because, of course, calcium is a really durable, rigid substance that the body uses to wall it off. And that is why those tubercles actually show up on an x-rays. There's some calcium in there. So in countries where TB is much more common, they have a routine vaccination they give to children called the BCG vaccine, but it also is not 100% effective. So in this country, we use surveillance primarily to limit the spread, so those tests that we just mentioned. If you have a positive case, then isolating the patient in a room with a HEPA filter primarily to protect others in the facility as opposed to the patient themselves. N95 masks then protects individuals in contact with the patients. Treatment, of course, requires not only multi-drug regimens, but also very long-term. So these bacteria are very slow to grow. So when we say long-term, it can be from 6 months to 2 years in some cases. And we do have much resistance that has developed. And so we have multi-drug resistant and extensively drug resistant. And in most cases, those are going to actually be require of the patient to take directly observed therapy, or DOT, which means they actually have to be watched to confirm that they're taking their medication on a daily basis. Because these are such dangerous strains, when you get that extensively drug-resistant condition, there have actually been cases where patients who refused to take their therapy were incarcerated because they were likely to spread a very dangerous infection.
So, another vaccine preventable disease of the respiratory system involves a gram negative bacteria called Bordetella pertussis, and it has a variety of virulence factors that lead to this disease. One of which is called fimbrial hemagglutinin, and this basically just allows these bacteria to stick to the cilia. And then once they establish themselves, they'll start secreting pertussis toxin, which then paralyzes the cilia and also induces the cells lining the trachea to actually make more mucus. So that just really starts predisposing the system to being very thick sputum. And then you have another toxin called tracheal cytotoxin. Now, when it first gets secreted at very low concentrations, it sort of works with that pertussis toxin to inhibit and paralyze those cilia. But as the disease progresses, it actually kills those cells of the trachea, and so then they start sloughing off and they become part of that very thick sputum. And this is really where the symptoms are associated with this. So there are four distinct phases for this disease. You have an incubation period of about 7 to 10 days. You then have a catarrhal stage, which is about 1 or 2 weeks worth of what looks like a mild cold. And then you go into the paroxysmal stage, which is really where you have these convulsive attacks of repetitive coughing. And babies are particularly susceptible to this, and they literally can cough to exhaustion, and they'll burst blood vessels in their eyes, and they'll become cyanotic because they're coughing so much they don't actually inhale. And so it becomes really problematic. And then even if they get past the infection, they have a convalescent stage that can last for several months, where that cough just very, very slowly subsides over time, and they're still highly susceptible to secondary infections. So this is a horrible disease for infants in particular. And unfortunately, proper diagnosis is really difficult because after the first 2 weeks or so, the tests that are available, they lead to a lot of false negatives. And so we just said 2 weeks, right? You're still in that what looks like a common cold, and they may not think to test for pertussis until it's too late. Treatment is also only very effective in the first couple of weeks, which again is still going to be suspected that it's just a common cold. And so during the stages of the disease, one of the worst things you can do for these patients is to give them cough suppressants, right? That mucus is already building up. And so if you give a cough suppressant, then it's just going to add to that. So it's really just sort of a vicious cycle, right? If you have a baby that looks like they have a common cold, of course, cough suppressants are going to help them sleep and things like that. So it's really hard to deal with. And again, this is a vaccine preventable disease. We have the P associated with a DTaP vaccine is the pertussis. Now, we've seen a resurgence of this infection even in the US where we have vaccination rates, and partly it's because research is suggesting that that adults really have what we call waning protection, right? So we get this, we don't get pertussis boosters. And so there's some evidence that maybe a booster is warranted. There's other evidence that shows maybe the genetics of this organism, they have mutated slightly from the version of the organism that we made the vaccine against originally. So they may just need to update the vaccine so that it matches the current evolutionary version of the bacteria. But you add those two things together with the anti-vax movement, and that all of them sort of, it's like the perfect storm why we're seeing a resurgence of this disease. So it's become a problem even in countries where we do have vaccination.
So diagnosing pertussis can sometimes be difficult because the tests that are used have different levels of sensitivity, and so when the individual is tested is really important. And so unfortunately in those first few weeks, when it just looks like a typical cold, is when it's most readily diagnosed effectively from PCR and culture. Unfortunately, we don't always test them early enough, and so if they do a serology test later, it's more optimal time to do a serology test as opposed to the other ones. So pertussis is one of the diseases that is a component of the DTaP vaccine. So it is a routine vaccine preventable disease. Primarily supportive care when it comes to treatment. The antibiotics are really most effective in the first 3 weeks, and as we mentioned, sometimes those symptoms are not really obvious. We talked about how cough suppressants are actually one of the worst things you can do for a pertussis patient because it's just going to add to the thickness of that sputum. And again, susceptibility is primarily children who don't get the vaccine. And the most severe disease we see is in the youngest patients, so under the age of 5. Then we have diphtheria, which is another bacterial disease of the respiratory system. So Corynebacterium diphtheriae. This is also transmitted through respiratory droplets, but can also be transmitted through direct contact. Depending on where the infection is, those tissues are also infectious. Also vaccine preventable through the DTaP. This is the D in DTaP. And also there's a 10-year booster typical of diphtheria. And so this is when we give the tetanus booster, that's the D in the tetanus booster. And so because they both require about a similar booster cycle. And so again, antibiotics are effective if it's diagnosed properly, but because the toxins are the ones that are really doing the damage, antitoxins. So we do have antibodies that we can also give to help prevent progression of the disease.
So we tend to think of diphtheria as an ancient disease, mostly because in this country and modern countries in general, we have regular vaccination programs against this disease. But it's still a big problem in parts of the world, especially the developing countries, where they don't have regular vaccination. So the severity of this disease really depends largely on the immunity of the patient, but it can have a 10% fatality rate. So it is a serious disease. Diphtheria toxin is produced only if the bacteria has been lysogenically converted. So if you recall, that means there's a bacteriophage present, and it's got the gene that produces this protein, which is diphtheria toxin. And this toxin will get released from the bacteria and travel through the bloodstream. And so it can cause problems in organs that are distant from the respiratory system. So for example, it can affect the heart. In myocarditis, it can cause paralysis of different muscles like the diaphragm or the soft palate. One of the first symptoms is sometimes difficulty swallowing. And mostly it does that because when it gets into those other tissue cells, it blocks protein synthesis and essentially kills the host cell. But one of the biggest problems with this disease is the fact that once it creates a biofilm, the way your body responds to it and the secretions coming from the bacterial biofilm create what's called a pseudomembrane. And this is sort of a thick, leathery type of tissue. In fact, the word diphtheria means leather. And this pseudomembrane can grow so large that it obstructs the entire airway. So it's really a horrible way to die. This is, they basically die from suffocation if they don't surgically remove this layer from the pharynx. And so this, of course, is a vaccine preventable disease. So we have a regular program where we start out with the DTaP, which is diphtheria, tetanus, pertussis series of a combination vaccine, and then we have 10-year boosters that are a combination of tetanus and diphtheria. So we have the DTaP originally, and then we have the TD every 10 years, or sooner if you have an exposure that they worry about tetanus. But there's a new study actually that shows that there may not be a need for that 10-year booster. So in fact, countries like the UK, they've never given the boosters. They've always just given the original series of shots in childhood. And so there's been a long-term study now that shows there's no difference in those cases of diphtheria across the different countries that do and don't give boosters. Now, out of an abundance of caution, the CDC is still recommending our 10-year booster. but it could save millions of dollars if they make the decision to not give those boosters. But obviously, these are dangerous diseases. You don't want to you want to remove that cautionary process.
Now recall we talked about cutaneous anthrax, but there's also an inhalation or pneumonic anthrax, which is of course caused by Bacillus anthracis, and this is the most severe form of an anthrax infection. And so this is not something that can spread from person to person. It requires contact or inhalation of those bacterial endospores to progress. And so the early signs and symptoms resemble a cold or a flu, but then we know it will progress to very severe cough, shortness of breath, and even can be fatal. And so again, the diagnosis here requires identifying the bacteria in a sputum sample. We do have a vaccine, but again, it's limited to military. It's not a very user-friendly vaccine, and it's highly unusual that people will come in contact with the anthrax endospores. And so we do vaccinate our livestock against it, which historically was the primary contact between the endospores and humans. And so unless you're in direct contact with an anthrax patient or a researcher, it's probably unlikely that you would routinely get that vaccine. So treatment, we've talked about the fact that because of the severity of the damage to the lungs, early and aggressive treatment is absolutely critical to avoid death through inhalation anthrax. And so we do have antibiotics, but it also requires persistent draining of the fluids that begin to build up in the respiratory tract. So any damage that's done to the lungs, unfortunately, cannot be repaired. So treatment really needs to be early and aggressive. And even with treatment, there's typically about a 50% mortality rate. So this is why we worry about, for example, biological weapons when someone gets an unusual package that's got powder that they suspect it could be anthrax, because if you don't know you've had an exposure, it can be deadly.